Christopher Paris. I'm an interventional cardiologist with Cardiovascular Institute of South, practice out of Luling, Louisiana. And I'm going to speak today about how to establish an effective PERT program in your local hospital. Here are my disclosures. Basically, some background. PERT stands for Pulmonary Embolism Response Team. Right at the moment, as we go through these courses, you'll see there's not well-known guidelines for treatment options for pulmonary embolism patients. The idea of this was to develop an expedited care for these complicated PE patients, but with the increased collaboration of multiple specialties. Treating a PE is not just a one physician job. You have anywhere between cardiologists, radiologists, surgeons, ER doctors, hematologists. So they wanted a way in order to collaborate everyone together so that the best treatment option can be delivered the quickest and safest. So the philosophy comes from actually two system-based teams we already have today in the cardiovascular world. The first is the heart team, and the second is the rapid response team. What the heart team does when it comes together, it has multiple cardiovascular specialties from surgery and from cardiologists, along with anesthesiologists and radiologists, to determine the best treatment for our TAVR programs and our other different types of complicated heart patients. They come together, they have a meeting, and the best outcome are shown when more people come together and agree on the plan. The rapid response team is similar. It has multiple physicians, nurses, and other people in the hospital that come together very rapidly to treat an acutely ill patient, and they have protocols to deliver the best care quickest. So the PERT came from that philosophy, and then the concept, which is written out, is to leverage the input of multiple medical specialties for the expedited assessment of the intermediate to high-risk PE patient and develop a coordinated treatment plan. All this is in an emergent situation to develop best care. The first PERT team was established at Mass General in 2012. Since then, about 19 programs have started in the United States, and it continues to grow each year. Before thinking about starting a PERT, you guys see what type of preparations that you need in order to begin. The first is you need to compose a group of physicians and specialists who are interested in treating acutely ill PE patients. But they also have to be comfortable in a shared decision-making model, because that's the whole idea and beauty of the PERT team, is that multiple physicians come together with multiple ideas. Having a PERT champion, one physician who pushes for this at your institution, is very important, because you need administrative support in order to develop this program. Also, you need to evaluate what your institution's ability is to develop these advanced PE therapies, such as some here, ECMO, thrombectomy devices, post-care, real-time meeting capabilities. These are all needed in order for a PERT team to be successful. Also, you got to evaluate your manpower. Most PERT programs at the present time are in training programs, so you have many fellows and residents to help. Larger community-based hospitals, they use the frontline clinicians, such as the ER physicians or the critical care physicians, to be the frontline person. But that's a big thing you need to evaluate, is if your hospital can accommodate these teams. Once you know you can accommodate it, then you need to initiate. The very first thing you have to do is educate. You have to go educate everyone in the hospital, from grand rounds to just team meetings, because like we all say, there's not too much data right now on how to treat PE patients, and there's not an algorithm or a certain protocol. So this is where the beginning, you need to introduce what a PERT team is to the institution and show what outcomes can possibly come about with the data that's already collected. Next, you need to target and continually to engage the subspecialties that see the highest initial contact with PE patients, mainly the ER, critical care physicians, and the primary care physicians into our office. Weekly, bi-weekly meetings, having all the phone numbers known. These are the patients these are the physicians that see the worst patients the most acutely and quickly. So therefore, having them know exactly what a PERT can do for them is vital to the survival of the program. Also, before the PERT physicians want to start off treating patients, protocols need to be developed and agreed upon within the group, so that when the PERT team is released, everyone can be on the same page about the therapies, about the initiation of the consult, and how follow-up is going to be done. The major keys for the success depends on the ability of key 24-hour clinical services in the hospital, mainly ER, having 24-hour radiology reading availability, having a 24-hour cath lab, and having 24-hour OR. Hospitals are going to have to tailor their PERT abilities and responses according to their infrastructure. The biggest one seen so far is the advanced OR procedures for surgical thrombectomy. If you want to develop a PERT program in a hospital that doesn't have that, at this time it'd be a good decision to make a relationship with a tertiary hospital which is near to you that can provide that service, so that if an advanced OR service is needed, transfer can be expedited quickly to the tertiary hospital you have a relationship with. And then also the PERT physicians must meet routinely to promote education and PEs among themselves. Like I said, the PE field is expanding quickly, and having routine meetings once a month to make sure everyone's on the same page, everyone's bringing new data, and outcomes are being evaluated and improved is a way to keep the team strong. Here, operations. So here's a flow sheet of how a PERT team works. The referring physician is usually the ER doctor or critical care doctor. They call one number, and it's a 24-hour call center. That one number, that call center then calls, most places, a vascular fellow, but it can be your frontline physician. That person is responsible for collecting all the information. They accept the consult. They then present the information to the PERT conference call. And this is usually a list of people involved on the PERT team. They meet, and then a decision is made. Let's go a little bit more into the PERT conference call. The PERT conference call usually convenes on an online meeting software. Because remember, it's 24 hours, it can happen 1, 2, 3 in the morning. Usually 8 to 10 physicians join this virtual meeting, and it usually lasts 15 to 20 minutes. That one fellow or clinician presents everything to the committee, then summarizes the plan. That one physician then goes to the consulting physician, gives the recommendations, and the fellow is then responsible for mobilizing the treatment plan. The goal for this whole process, from the initiation of the consult to the beginning of treatment, we try to keep within 90 minutes because these are intermediate to high-risk PE patients. PERT is also responsible for data collection. And this is going to be very huge in the future for these programs to continue to develop, and for medicine in general to get protocols and treatment options which will give us the best outcomes for our intermediate and high-risk PE patients. Then lastly, on discharge, the PERT team is responsible for arranging post-PE care, such as make sure they're on their right anticoagulation, do they need ultrasounds, echoes, or whatnot. So they will be responsible for the post-care along with the discharging physician. Challenges today we have for PERT is that not too much data exists. The first one was only started in 2012. So all the data so far is short-term data in the form of registries and cohort data. But data is building more and more, and that's why the PERT groups are functioning well, because they are controlling the data, and that's one of their main missions, is to provide more data. So this will increase exponentially by year. And the challenge is to keep the physicians that dedicated and persistent to take the call, provide the treatment, and collect the data in these patients where the financial reimbursement is not really there yet. They're working on providing ways to compensate the PERT teams and hospitals, but at the present time, we need more data in order for the financials to come. So majority of physicians on the PERT team are dedicated physicians that want to treat PE patients, have the best outcomes, and are passionate about their care. So in conclusion, the PERT concept was developed to provide high multi-specialty medical approach to the indeterminate high-risk PE patients. And it was done in order to initialize a protocol for best care of treatment for these patients, as very little data does now exist. Physicians with an interest in treating PE, widespread education to frontline colleagues, and administrative support are all essential to initiation, operations, and the continuation of these PERT programs. Data collection is being continued to grow and show great responses for PE patients that are treated in this outcome. It's following very closely from the initiation of the heart teams, how this combined multi-specialty group provides great outcomes, because you have multiple minds coming together. And more programs are being built. So therefore, we'll have more data. And hopefully soon we can have protocols that can be put into guidelines for treatment of the high-risk intermediate care PE patients. Here's my references. Thank you very much.